This lecture is on skin and soft tissue infections. We'll be covering 4 clinical scenarios, which are cellulitis, cutaneous abscesses, diabetic foot infections, and necrotizing fasciitis. So beginning with cellulitis, this is acute infection involving the skin and the subcutaneous tissues. And the common pathogens are largely the gram-positives, Streptococcus pyogenes and Staphylococcus aureus. The diagnosis is largely clinical, and the picture shows you a typical case with a unilateral, red, swollen, painful leg. The differential diagnosis is important. We'll be covering necrotizing fasciitis later, but you must consider deep vein thrombosis, insect bites, and drug reactions. In terms of diagnosis and management, you first need to assess the severity of the condition. Ask yourself, is there rapid spread or extensive disease? Are there prominent systemic inflammatory responses or significant comorbidities? If not, then outpatient therapy is appropriate, and a reasonable choice would be flucloxacillin given for 5 days or extended to 10 days if there's a slow response. If the patient's more unwell, however, they will require inpatient therapy, and an appropriate choice would be cloxacillin 2 grams IV. After 72 hours, you should assess the patient for their clinical response. If they've responded well, then you can make a prompt IV to oral switch using flucloxacillin. But if they've not responded, you must consider complications such as collections or underlying osteomyelitis. You should take a blood culture, and it may be reasonable to switch to clindamycin either orally or intravenously because of its good soft tissue penetration. Moving on to cutaneous abscesses. These are deep inflammatory nodules extending into the subcutaneous tissue that develop from a preceding folliculitis. The common pathogen is Staphylococcus aureus, and as with cellulitis, the diagnosis is largely clinical. The differential diagnosis would include tuberculosis, i.e. a cold abscess, or a cyst. In terms of treatment, it's important that all cases of cutaneous abscess require surgical incision and drainage. Antibiotics are only required in complicated cases, that is, if there's surrounding cellulitis, if the abscess is located on the face, or if there are systemic symptoms. Usually oral flucloxacillin will be appropriate. An alternative would be coamoxiclav. In patients with penicillin allergy, clindamycin would be a good choice. Turning to diabetic foot infections, these are classified into mild, moderate, and severe. Mild is when the infection is limited to skin and superficial subcutaneous tissue and is less than 2 centimeters beyond an ulcer margin. Moderate is when cellulitis is greater than 2 centimeters, there's deep fascial involvement, gangrene, an abscess or osteomyelitis. And severe is when the patient has systemic complications. The etiology varies according to the severity and whether there's been previous treatment. So in mild cases which are previously untreated, the causative organisms are usually Streptococci and Staph aureus. But in chronically infected diabetic feet or patients who've had previous treatment, in addition to Streptococci and Staphylococci, there may be Enterobacteriaceae. And in patients who've got chronic diabetic feet with multiple courses of antibiotics, in addition, they may be infected with Pseudomonas or anaerobes or Enterococci. In terms of investigations, none are required in patients with mild, previously untreated infections. And superficial swabs sent for MCNS are of no use in diabetic feet and should not be performed. In all other situations, tissue cultures are recommended. It's important that these are taken well. It's essential to clean and debride the lesion before you're obtaining a specimen for culture, rather than sending a swab from tissue that is going to be removed. Blood culture should be performed in all patients with severe infections. Diagnosis is clinical and based on a diabetic patient with a foot ulcer having other features of infection, such as pain, induration, and erythema. The antibiotic choice depends on the severity. Those with mild infections can be treated with flucloxacillin as an outpatient. Moderate infections should be treated with coamoxiclav, and severe infections are likely to require intravenous coamoxiclav. If patients have penicillin allergy, mild to moderate infections can be treated with clindamycin and with the addition of ciprofloxacin if admission is required. And severe infections should be treated with intravenous clindamycin and ciprofloxacin. Surgical consultation is essential if any of the following complications are suspected: a deep abscess, bone or joint involvement, crepitus or gangrene, necrotizing fasciitis or severe vascular insufficiency. Moving on to necrotizing fasciitis. This is defined as acute severe infection involving subcutaneous tissues, including the fascial layers. Usually it's precipitated by trauma or surgery, a perirectal abscess, perhaps bed sores, or a bowel perforation. It's usually polymicrobial, that is to say there are multiple different species of bacteria causing the infection. These include streptococci, enterobacteriaceae, and anaerobes. In terms of diagnosis, there is usually associated systemic toxicity manifested by fever, leukocytosis, raised inflammatory markers, and there may be organ dysfunction. However, a predominant feature in necrotizing fasciitis is pain, and a key marker is that the pain is out of keeping with the clinical features of infection. Necrotizing fasciitis can progress rapidly to cutaneous gangrene, and the treatment is early and aggressive surgical debridement plus antibiotics. It should be emphasized that the early and aggressive surgical debridement is the primary therapy, although antibiotics should also be added. Usually intravenous coamoxiclav will be appropriate, and blood cultures should be taken, and surgical tissue specimens should also be sent for microbiological examination. If coamoxiclav is unavailable, then ampicillin plus metronidazole and gentamicin, all given intravenously, would be appropriate. And patients with refractory infections or penicillin allergy, clindamycin plus ciprofloxacin, both given intravenously, would be appropriate. So in summary, all abscesses need incision and drainage primarily. Flucloxacillin or cloxacillin is the drug of choice for skin infections due to Staph aureus, with clindamycin being an option in penicillin allergy. Take tissue biopsies to guide therapy in chronic or complicated diabetic foot infections. And necrotizing fasciitis is a serious condition which needs urgent surgical intervention.